Good afternoon. My name is Dr. Susan Rubman. I'm a clinical psychologist and I work in both transplant and sleep medicine at Yale, and I have the privilege of speaking to you today about sleep in general and sleep in Wilson disease. An important bit of housekeeping. I have no relevant financial disclosures and I have no conflicts of interest to disclose. Also, I'd like to encourage you to send in questions as they occur to you rather than wait till the end of the presentation so that I can answer your questions most efficiently after the formal presentation. And with that, let's begin. I'd like to present an overview of what you'll hear about in this next half hour. We're going to talk about normal sleep. We need to talk about what sleep is before we talk about what it isn't. We'll talk about types of sleep problems in general and those specific to Wilson disease. We'll talk about insomnia. We'll talk about sleep tips and tricks, and we'll talk about when to seek help. So I want to show you what a normal night of sleep looks like. So if you were to have an overnight sleep test in the Sleep Disorder Center, you would be hooked up to a variety of wires and sensors and transducers, all of which measure different aspects of sleep. Eventually, each of those sensors would be read and would come together to form a hypnogram or a picture of your night's sleep. And I want to show you what that looks like. Sleep comes in 4 different stages, very cleverly named: stage 1, stage 2, stage 3, and then dream sleep. And we can see those aligned along the left side of the graph here. And we have wake, stage W, at the top. Dream sleep is marked by a green bar, and you can see these are episodes of dream sleep that occur throughout the night. We move through the stages of sleep, lighter and deeper stages of sleep, kind of like a carousel horse moves, going up and down and around in a circle throughout the night. So an individual starts out awake, goes to stage 1 sleep, stage 2, and stage 3, and comes back up to stage 2 and may have a dream, and then goes back down to stage 2 and back to stage 3 and back up to stage 2 and may have another dream. And what I want to highlight to you is something very important that occurs here and here. These are wake-ups. It is utterly and completely normal to experience some wake-ups during the night. Every individual, in fact, wakes up between 2 and 6 times every single night. It's also important to note that sleep is a very active process. There's a lot going on during sleep that we actually don't and can't know anything about. It's a process that we don't actually have much access to as in terms of our conscious ability to understand what's happening. So this is a normal night. About 50 to 70 million Americans have sleep disorders. Let's talk a little bit about that, and a little bit about more normal sleep first. This graphic is from the National Sleep Foundation. It's from 2015, and it's important because it recognizes the lower limit of normal sleep really for the first time. We see hours of sleep here on the left and ages of individuals across the bottom. We're going to focus our attention up here in the adult section. The teal section represents what might be appropriate or might be acceptable, and in many cases is. The dark blue section represents what is considered recommended. Notice that it doesn't say 8 hours is recommended for all individuals. There's a recognition, there's a range of what's normal for different people. And for some people, 6 hours may be sufficient. I also want to highlight that, that as we get older, and here it's defined as 65 or older, conversation for another day. But as we get older, we don't actually need less sleep. We just actually obtain sleep a little bit differently. So now that we have a basic understanding of what normal sleep is, I want to move into talking about challenges that we might have with sleep. We can divide problems with sleep into 2 broad categories for today's purposes. The first is problems which occur during sleep, and those are obstructive sleep apnea, which are pauses in breathing of 10 seconds or longer during sleep. Those are associated with a drop in our oxygen saturation because as we pause, we don't take in new oxygen to use up to replace what your body is already using. These pauses in breathing are often associated with little tiny wake-ups at the end, and for clinically significant obstructive sleep apnea, it's associated with significant health risks. Periodic limb movement disorder also occurs exclusively during sleep, and these are little tiny leg jerks that occur in clusters across the night, and those are often also associated with little tiny wake-ups, which are disruptive of sleep. And finally, we're going to talk about REM sleep behavior disorder. This occurs only during dream sleep. REM is rapid eye movement or dream sleep. And in this condition, individuals physically act out vivid, often unpleasant dreams with vocal sounds and sudden, often violent arm and leg movements, or they may fall out of bed or engage in what looks like purposeful activity. Generally, we are largely paralyzed during dream sleep. The nerve pathways in the brain that prevent our bodies from moving are typically in charge during dream sleep. But in REM sleep behavior disorder, these pathways don't work quite well, and they enable individuals to physically get up and act out their dreams. This can result in injury from falls or unusual behaviors because sleepers react to what they are perceiving in their dreams rather than what's in their environment. So, for example, if someone were dreaming that they were trying to fend off an intruder, they may injure themselves trying to wrestle a floor lamp to the ground or trip over objects in their way. This is different from sleepwalking, as it is almost always associated with detailed dream recall, and it only occurs during dream sleep or REM sleep. We'll talk a little bit more about REM sleep behavior disorder in a moment. Problems related to falling asleep or staying asleep, as opposed to those that occur actually during sleep, take two forms. The first is restless leg syndrome, and unlike periodic limb movements, which only occurs during sleep, restless legs only occurs when we're awake. It's an uncomfortable sensation in our legs that feels like there might be something crawling on our legs or under the skin, and it's very distressing, only relieved by movement. And it disrupts falling asleep because of that uncomfortable sensation. Individuals may need to get up and walk around or stretch or rub their legs together in order to make the sensation subside. And then finally, insomnia, which is something that we're going to talk about in more detail in just a moment. Let's narrow our focus now to talk about sleep in Wilson disease specifically. Sleep disorders are actually relatively common in Wilson disease. In a recent meta-analysis and systematic review of the literature, it was noted that 54% of patients will experience sleep disorders. Note that this is a higher percentage than the 1/3 of Americans who typically report sleep disturbances. Insomnia is the most common sleep disorder in patients with Wilson disease, as actually insomnia is the most common sleep disorder in general. It may be related to a variety of factors, including mood disturbances and some medications that may be used to treat the symptoms of Wilson disease. REM sleep behavior disorder, as we just discussed, is the next most common sleep concern in patients with Wilson disease. REM behavior disorder in general is related to metabolic abnormalities that affect brain chemistry, particularly associated with the chemistry of dream sleep. More specifically, for patients with Wilson disease, according to recent literature, it may be some dysregulation of the brain chemicals associated with copper deposits in the brain, or it may be that possible changes in the neurotransmitter dopamine, which may occur as a result of other processes with Wilson disease, produces REM behavior disorder and increases the incidence of this in the Wilson population. There are data that suggest, though, that when Wilson disease is treated and controlled, REM behavior disorder symptoms improve or resolve. Finally, there's no evidence of increased incidence of sleep apnea in Wilson disease. Let's move on to talking about insomnia specifically. Again, we need to talk about what insomnia actually is before we talk about how to resolve it. So the clinical definition or the clinical criteria for insomnia are that it takes longer than 30 minutes to fall asleep. Individuals may wake up frequently throughout the night, and that's more than the 2 to 6 times that we typically wake up, or they may be awake for longer periods, greater than 30 minutes during the night. So whether they wake up frequently and in the aggregate are awake for longer than 30 minutes, there's a recognition that there is disruption of sleep during the night, or they may wake up too early in the morning. And all of these must occur in the context of getting less than 6.5 hours of sleep per night. This also must occur 3 or more nights per week for 3 weeks or more. This is to highlight the idea that there's natural variability in sleep and that some nights are simply going to be better than others for a variety of different reasons, whether it's related to something that occurred during the day that was challenging or stressful or actually very exciting, or whether it's environmental conditions. But there will always be variability in sleep, and so the criteria for insomnia require more consistency and duration. So what do we do with insomnia? There are 2 paths to treatment: pharmacologic and behavioral. Cognitive behavioral therapy for insomnia is a set of behavioral strategies that are evidence-based and are the standard of care for treating insomnia in the general population. This treatment has also been repeatedly validated in multiple clinical populations as well, including patients with chronic pain, cancer patients, and patients with other metabolic disorders. I want to speak specifically about behavioral strategies to improve sleep, and we'll leave the discussion of sleeping medications for another day. So these are the starting points of managing insomnia. These are the nuts and bolts. The first guideline is to not get into bed until you're sleepy, not just tired, but actually ready to go to sleep. We want to increase the likelihood that when we get into bed, our bodies are going to be prepared for sleep and not extend the time that we may lie in bed tossing and turning. Similarly, it's actually essential to maintain a consistent wake-up time. Even if it sounds counterintuitive, getting up at about the same time each morning resets your body's internal clock, your circadian rhythm, and this increases the likelihood that you'll be able to fall asleep at your desired rise time. When we get up in the morning, a signal is sent directly to your brain to start a countdown clock in order for your body to recognize the time for sleep. We limit time in bed to about 8 hours. Sometimes people want to extend their time in bed thinking that they might be able to get more sleep. What typically happens with people with chronic insomnia is that the more time they spend in bed, they don't necessarily change the amount of time they sleep, but they spend more wake time in bed. And that becomes, sleep becomes less satisfying and patchier throughout the night. So by limiting the amount of time in bed, we consolidate sleep and sleep becomes more restful. The recommendation is that if you must nap, set an alarm for no longer than 45 minutes after the time that you lie down, ending no later than 2 p.m. Taking a nap later in the day is like having a really, really big snack before you sit down for a meal. If we sleep later in the day, our sleep drive, our need for sleep is decreased, just like if we have a big snack before a meal, our hunger is decreased. So we want to give more time between any potential nap and our bedtime. These strategies are just the most basic rules, and many people have heard them. They don't work quickly, and they do require consistent administration, just like antibiotics require consistent administration to fight off infection. But these and other specific rules of treating insomnia are very effective. It's important to note, if you are acutely ill or if your doctor recommends otherwise, modify these guidelines as you need to. General sleep strategies, and these are tips and tricks that are good for sleep for everybody. Set the stage for good sleep before bedtime. Make sure that the environment is conducive to sleep. Reduce our exposure to blue light that is often produced by handheld devices and sends an alerting signal to our brain. The blue light produced in these screens is similar to sunlight, which is a natural alarm clock for our brains. So we ask that folks try what's called night shift mode. It's a setting on our devices to eliminate the blue wavelengths. Set aside some time to wind down and allow your body to settle before bedtime to allow us to more smoothly negotiate that transition to sleep from wakefulness. Developing a consistent bedtime routine is very helpful in allowing your brain and your body to recognize what comes next in the routine. So when we do things in kind of the same way each night, maybe walk the dog, clean up the kitchen, wash your face, brush your teeth, put on pajamas, read for a little bit, or watch TV. When we do those things consistently in the same way, behavior follows like links in a chain, and sleep is more likely to occur consistently. We also recommend discharging all that excess activity in your brain, make a list of things that you need to do the next day, maybe keep a pad somewhere nearby and write things down before you get into bed so that you don't have to worry about remembering them during the night. We recommend, in terms of the optimal sleep environment, that it is cool, dark, and quiet. The recommended temperature for sleeping environments is actually less than 68 degrees. Avoid caffeine within 6 hours of bedtime. Caffeine has a 6-hour half-life. The data on caffeine and sleep are elegant and very clear. The more caffeine we consume, the more awakenings there are, whether people recognize those awakenings or not. Which sounds kind of funny, but the data show that when people are given caffeine prior to bedtime, they experience more awakenings. Consider a small carbohydrate snack before bedtime so that we don't wake up hungry during the night. If you wake up during the night, remember that many wake-ups are just typically normal, 2 to 6 times every night for all individuals. It's recommended that we avoid active or productive pursuits during the night because those are likely to keep us awake longer. Finally, in the morning when we wake up, we use the acronym CLAP to help us achieve and maintain wakefulness during the day. A little bit of caffeine, light, preferably sunlight, because remember it sends an alerting signal to our brain, activity, and protein. These 4 things set the stage for us to successfully negotiate that transition from sleep to wakefulness. Finally, when to seek help. If you have trouble with sleep for 3 weeks or more, going back to that original criteria for insomnia, if your sleepiness interferes with your life, or if you fall asleep unpredictably or in dangerous situations like driving or using machinery, if you've been sleepwalking, acting out your dreams, or have fallen out of bed during sleep, it is likely time to seek help. And finally, if you're worried about your sleep, because simply worry about sleep can interfere with sleep, and there is effective help available. Speak with your physician or ask for a referral to a sleep disorder center, as there is help. So I thank you for your attention, and now I'm happy to address any questions. Good afternoon. I'd like to remind you that I'm here to take your questions, and you may need to scroll down and open up the questions section to send your questions to me, and I'm happy to speak to the things that you are curious about. Let's see, we have a couple of questions here. The first one is night sweats a common sleep problem in Wilson disease? That's an interesting question. Night sweats in and of themselves are not a sleep disorder. It's not an independent sleep disorder, and there are lots and lots of things that cause night sweats. So, for example, at its most simple level, environmental factors will cause night sweats. There are metabolic concerns that cause night sweats, such as pregnancy, or maybe the opposite of pregnancy, which is perimenopause. Individuals with obstructive sleep apnea, particularly untreated obstructive sleep apnea, can experience night sweats. I am not aware of any specific link to a sleep disorder with night sweats in Wilson disease, though. I'm not sure if that answers your question, but I hope that it does. Let's see. Can I provide any information on why mid-sleep waking and early waking causes kaleidoscope vision? Interesting question. So first, let's define our terms a little bit. Kaleidoscope vision is waking up with, or not waking up, but experiencing colors and distortions in the vision, much like you would when looking through a kaleidoscope. Again, there's no specific sleep disorder that is associated with kaleidoscope vision. Kaleidoscope vision is sometimes associated with migraine. One of the things that happens, though, when we wake up during the night, again, there are normal wake-ups, and then there are wake-ups that are more challenging. But sometimes when we wake up, there's kind of a brain signal mismatch. Part of your brain is saying it's time to be awake, and part of your brain is saying it's time to be asleep. And so there can be kind of confusional arousals or misperceptions. I would think that in the absence of any other clinical syndrome like migraine or other neurological concerns, that might be what's causing the issue or the concern. I would also be curious about low levels of lighting, because it's during sleep that could cause visual distortions. Let's see. Is dopamine associated with REM behavior disorder? Yes, dopamine metabolism is in fact associated with REM sleep behavior disorder. And the question is high levels or low levels. So let me just say that it's a complex relationship between dopaminergic neurotransmitters and REM behavior disorder. As evidence of that, we know that Parkinson's disease, which is a dopaminergic concern, is highly tied with REM behavior disorder. And in fact, REM behavior disorder can be a prodrome for Parkinson's disease. Our best awareness is that low levels of dopamine are typically associated with REM behavior disorder, but this is an ongoing and complex area of research. Oh, the questions are flying in. So next question. My sister with 45 years of Wilson disease has sleep problems, normal recent sleep study, which is great to hear. Stays up until 3 or 6 a.m. and then sleeps most of the day, can fall asleep and it sounds like she's falling asleep unpredictably and doesn't have insomnia. So as I had said earlier, there are types of problems associated with falling asleep or staying asleep, and then there are problems that occur during sleep. So one of the things that happens is sleep is regulated by our circadian rhythm, our internal clock, and that determines largely what time of day we're going to sleep. Somebody who is regularly falling asleep in the early hours of the morning, the first thing that comes to mind is, and falls asleep in the early hours of the morning and then sleeps later through the day. That sounds like there may be kind of a mismatch between the time somebody wants to sleep and what their circadian rhythm is suggesting. So when somebody sleeps throughout most of the day and they wake up late, getting up is what sends the reset signal to your brain. So the later we wake up, the later we are likely to fall asleep, all other things being equal. In this setting, I would suggest that additional sleep evaluation is warranted. It's great to have a normal sleep study, but that doesn't address timing of sleep. So let's see. I easily fall asleep, but wake up between 2 and 3 a.m. regularly. So that's great. It's wonderful that you're not having trouble falling asleep. And as I had said, and it's really important to understand, every single human being wakes up multiple times every night. And sometimes folks get concerned that they wake up at a particular time. Again, that may be perfectly normal. I'm not sure if the question is that you wake up from 2 to 3 a.m., that may fall under the heading of insomnia, and then there are other things to do. But just the fact that somebody wakes up at a regular time, that's okay. If you remember that early slide looking at sleep stages, sometimes, we go through deeper stages of sleep and come up to lighter stages of sleep, and we cycle through. And it may be that as we come to a lighter stage, there's something that leaves us vulnerable to waking up at that particular time. But as an independent concern of just waking up at a regular time at night, I wouldn't worry about that. Do I recommend any kind of white noise or any apps that help with sleep? So in an environment that might have variable levels of background noise, if you live in a city and there's traffic, or if you live in a place where sirens might be going by, or cars, or a neighbor starting their car intermittently, like working third shift or something like that, white noise, or pets in the home actually also, white noise can be helpful because it acts as a mask of other intermittent sounds, and which can be disruptive of sleep. And so the white noise can actually help preserve sleep. Are there any apps that help with sleep? It depends on what you're looking for. There are certainly apps that generate white noise, brown noise, pink noise. Those are different frequencies. Some people prefer different sounds when they sleep. But in terms of apps for sleep disorder, CBTI Coach is one that is put out by the VA and is available to I think, to everybody. And in terms of helping with insomnia, that's a great first step. What are my thoughts on sleep trackers such as the Oura Ring? Oh my goodness, we don't have time for that. That's a great question. But the high level answer is all of those devices track factors that are associated with sleep. They can track heart rate, they can track heart rate variability, they can track movement. That almost all of them have an accelerometer, which tells you when you're moving around. And all of these things, some of them can go as far as to get oxygen saturation. All of these things are correlated with sleep, but they don't actually measure sleep. For people who have insomnia, sometimes those devices are more anxiety provoking than reassuring. The general 10,000-foot answer is, if it is reassuring to look at your sleep tracker, by all means look at it. If it causes you great anxiety, if you look at your sleep tracker, then don't look at it. But they can't actually measure sleep. They measure correlated things. I had a sleep study years ago and was told I never entered REM sleep. Can I help explain this? Absolutely. Not everybody goes through every stage of sleep in a sleep lab because it's a weird environment and it's awkward and uncomfortable. And sometimes people have disrupted enough sleep that they don't get into REM. The other thing is, if somebody has really significant apnea, their sleep may be so disrupted by apnea that they don't register a lot of REM sleep, dream sleep, because apnea will always be at its worst in dream sleep. And sometimes it's so disruptive that we don't see dream sleep on a PSG, a polysomnogram. What's my advice for someone who switches back and forth from night shift to day shift? Oh, that's also a whole separate talk. Rotating shifts is very, very difficult and really challenging for your circadian rhythm. What we most like to see, and this is a kind of a shorthand answer, we want to see overlap in your sleep period as much as possible. So if you're working thirds and you're sleeping from 9 o'clock in the morning till 4 o'clock in the afternoon, and if you're working firsts or seconds, you're sleeping at a different time, we want to have you overlap as much as possible your sleep on different working days, so that you're sleeping the same period of time in every 24-hour period. It's really hard to do, but there's lots more information available about managing shift work. Is night eating syndrome associated with Wilson? I have not seen any data to suggest that night eating syndrome is associated with Wilson. Having Wilson disease and now going through menopause is very difficult. I am sure that it is. My physician has me on Klonopin for sleep. What are my thoughts on clonazepam and Klonopin and sleep patterns? Goodness, these are great questions. There are lots of different agents that are helpful for sleep for different reasons. Clonazepam is a class of medications, benzodiazepine, that is historically used for lots of different things. In terms of its effect on sleep patterns, there are some drugs that influence our sleep stage distribution. Clonazepam is not one of those drugs. When people are using medications like clonazepam, we certainly want to make sure that there isn't an underlying disorder of sleep apnea, because some of those drugs can make apnea worse.
Okay, I have to stop you there. We have run out of time. Okay, thank you very much, Dr. Rubman.
My pleasure. Thank you.